Hi everyone, my name is Ben Brakel and I'm a second year medical student at UBC. Today I'm presenting a project where we introduce a technique with the potential to improve the surgical management of vestibular schwannoma and other neurosurgical procedures. Vestibular schwannoma is a benign brain tumor of the vestibular nerve and presents a significant challenge to neurosurgeons due to its delicate location and potential complications of resection, especially involving the facial nerve. Surgical resection is often curative but comes with inherent risks. Traditionally, the patient's head is positioned to maximize lateral head rotation and neck flexion to optimize the surgical field. However, our project delves into an operative aspect often overlooked, the impact these positions have on cerebral venous drainage and intracranial pressure. To begin, our extensive literature review sheds light on how head rotation and neck flexion can lead to occlusion of the internal jugular vein, and furthermore that this occlusion may elevate intracranial pressure and increase intraoperative bleeding. This may lead to suboptimal outcomes in such complex and prolonged neurosurgical procedures like vestibular schwannoma resections, and therefore we introduce a novel method of patient positioning to reduce this occlusion. To do so, our technique uses continuous, real-time monitoring of jugular bulb pressure during patient head positioning, which can detect obstructions in jugular venous flow when compared to systemic central venous pressure. This real-time feedback allows us to position the head and neck to minimize occlusions in cerebral blood drainage. To perform this technique, prior to the operation, a central line and jugular bulb pressure monitor are inserted by the neuroanesthesiologist as shown in Figure 1. The patient is positioned supine on the operating table with their head secured in a fixation apparatus, and the head is laterally rotated, flexed, and the neck flexed to optimize positioning. The jugular bulb pressure, central venous pressure gradient is then monitored in real time to assess venous occlusion, and the head and neck positioning is adjusted to reduce this occlusion and optimize venous return. As a proof of concept, we demonstrate this technique in a patient undergoing vestibular schwannoma resection. We first position them in the traditional fashion without using jugular bulb pressure monitoring, as shown in Figure 2a. The jugular bulb pressure was 10 millimeters of mercury higher than the central venous pressure, confirming occlusion of cerebral venous drainage. When head positioning was optimized, as shown in Figure 2b, the pressure gradient dropped to only 3 millimeters of mercury, demonstrating the efficacy of this technique. In conclusion, our research offers a promising avenue to improve the safety and success of vestibular schwannoma resections and other neurosurgical procedures. By optimizing patient head positioning based on real-time jugular bulb pressure monitoring, we may mitigate the risks associated with cerebral venous drainage occlusion and elevated intracranial pressure. We look forward to conducting prospective studies and furthering our understanding of this exciting and innovative approach. Thank you all for listening.